Hello and welcome to the launch of this Lancet series on work and health. I'm Jessica Bagenal, and I'm an editor at the Lancet, and I'm going to be chairing the session today. I want to start by thanking our authors who have worked tirelessly over the last 2.5 years to deliver this project, to the external peer reviewers who all constructively critiqued the series, to the internal editors who contributed also, to Richard Horton who supported the series and really honed down on the actionable recommendations, and to the World Health Summit for allowing us to launch it on this great stage. Thank you so much. I want to start by saying two things. First of all, this is just the start of an enormous amount of work that needs to be done in this field, and you'll hear from many of the people that are involved in furthering that research today. And second, and sort of along those lines, this is a very series that's focused on high-income countries, and there's a sort of urgent need for a really global perspective with a focus on low and middle-income countries, and I hope that that will come at some point in the future. And finally, thank you to all of you for coming to join us today. This series was conceived in the middle of lockdown, where many of us that were lucky enough to be in paid employment that could work from home were working in isolation, and we found new ways to work. At the same time, those of us that were essential workers or couldn't complete our tasks at home had to go out and often risk their own personal safety, whether this was in retail or agriculture or construction or indeed healthcare. And we all started to talk about this sort of huge divide between those that could stay at home and those that could go to work, how that impacted our ability to protect ourselves and how it impacted our overall sense of well-being. And alongside that, we shortly afterwards heard about the sort of great resignation, where people left their jobs in droves, or they exited the workforce altogether or started new jobs. We also heard about, contingent workers and those in precarious jobs trying to unionize, to take back some control over their work. The global economic crisis and the cost of living crisis meant that people were often having to work longer and harder in very poor working conditions to earn the same amount of money, just to provide food and shelter. And all of this along the sort of backdrop of the climate crisis impacting people's abilities to work, and also the drive for automation and the use of artificial intelligence, which continues to sort of remove opportunities from the workforce and to change the way that many of us work. And of course, with all of these stories and with all of these trends, there's a very layered intersectional approach to this that, changes the way that people experience it. There's a recent book called Wealth Supremacy, How the Extractive Economy and the Capitalist sort of biases are driving today's crisis. And in that, Marjorie Kelly, who's the author, she argues that there's sort of been a decades-long war against workers with anti-worker bias, and this has resulted in a crisis in the work's sort of place. And I don't think that we as a health community have really thought enough about that. So it's against that backdrop that today we launch this Lancet Commissioned series to start to explore the relationship between work and health. Is work good for us? How should we be thinking about it as a health community, and what should we be doing about it? These are the types of questions that we set out trying to answer. You'll hear from each, or a representative from each of the author groups, from each of the 3 papers in the series, and then we'll be joined by 2 authors from a linked comment that goes alongside the series for a panel discussion, and I hope if there's time that we can do some questions and answers, although we have only got an hour because unlike I think it's labelled as an hour and a half in the programme, but this is just a short session. So that's what's sort of in store. You'll hear how for too long we've focused on a very narrow sort of approach to occupational health that focuses on hazards and safety and not necessarily on the huge impact that our working conditions can have on our health. And knowing this, we propose that just as schools have become a place of health generation for young people, so too could the working environment become for the working population. The sort of how, what, why, and when of the working environment is really sort of underutilized levers for improving population health. So without further ado, I'll hand over to our first author, who is also the lead of this series and deserves special thanks for all of his efforts, Reine Ruglias. Reine is a professor of psychosocial work environment research at the National Centre for the Working Environment in Copenhagen, Denmark, and affiliated professor of psychosocial medicine at the section of epidemiology department of public health at Copenhagen University. Reine, over to you. And I'm going to go and sit over there I don't know if any of the other authors want to join us or you're going to come up separately.
Yes, thank you very much, Jessamy. Ladies and gentlemen, dear colleagues, dear friends, it's a great pleasure to be here to present our series on work and health that we just published a couple of days ago in the Lancet. So we are now going straight to these 3 papers and presenting them. The series was commissioned by the Lancet in 2021. It was about 2.5 years we worked on this, reviewed tons of literature. The series involved 15 authors from 9 countries and 5 continents, so we had a really international team. The papers went through a very comprehensive peer review process. We got many comments, and that helped to make the papers better. And then on 12th October, they were published, and under this link, the papers can be accessed together with an editorial and 2 invited commentaries. The main message of the series is that work is an undervalued lever for improving population health, and that major gains in population health and in reductions in health disparities can be made by an increased focus on improving the work environment. And we come to this conclusion by these 3 papers of the series: 1 paper on work as a social determinant of health, 1 paper on workplace mental health, and 1 on health and inclusive labor force participation. So we're going now through the papers. Paper 1, work as a social determinant of health. I'm doing this presentation with my colleague Yavin Cheng, who is joining us remotely. This is the paper, Work as a Social Determinant of Health in High-Income Countries, Past, Present, and Future. The authors were Professor John Frank from the University of Edinburgh, UK, Cameron Mastad and Peter Smith, Institute of Work and Health in Toronto, Ayuman Siddiqui, University of Toronto, Yavin Cheng, National Taiwan University, Alex Burdorf, Erasmus Medical Center, and I was also involved in this paper. The main message of this paper 1 is that improving working conditions has enormous potential for improving population health and for substantially reducing health disparities, as well as improving the quality of life of those with physical and mental disorders. And this paper has 3 major parts. We present a conceptual framework. We identify 6 emerging challenges with regard to work and health, and we come up with recommendations. And now I hope that Yaven is somewhere and can join us and can present the conceptual framework.
Okay. Thank you, Rainer, for taking lead in organizing this series, and thanks to the World Health Summit for having me on board. It's been an honor to be part of this work. In this article, we construct the overarching conceptual framework for our analysis. In this framework, we place employment conditions at the center.
Okay,
we propose that...
Excuse me, just interrupt because you are shown on the 2 screens, and if the technique can make it possible that Yaven is on one screen and the slides that are at here on the other screens, then I go through the slides, as we had discussed.
Okay.
Because if this does not, okay, here we go, everything fine.
Okay. Okay, so in this article, we have a conceptual framework for our analysis, and we place employment condition at the center. We propose that instead of investigating the health impact of individual workplace hazards, more emphasis should be placed on employment conditions. For instance, workers in permanent employment usually enjoy better working conditions, and those in precarious employment are prone to adverse working conditions and are usually more vulnerable in many aspects. And unemployment itself constitutes another threat, as unemployed people are often at risk for social exclusion. This framework also places emphasis on the impact of upstream social determinant of health, which include governance, politics, policies, economy, technological innovation, etc. This structural labor social determinant exerts differential influences on employment, working condition, and workers' vulnerability through different social pathways, and may enlarge or reduce social stratification, those having implication for health inequality. Next slide, please. So with this conceptual framework in mind, we highlight 6 emerging challenges as marked in yellow in this figure. So I will start from the first one. So next slide, please. So the first challenge concerns the impact of new technology. One of the emerging work types is telework. While telework may bring benefit to employers and employees, the digital divide exists, dichotomizing the workforce into 2 types. One can telework and one cannot. Those may create inequality in employment opportunities. Furthermore, there are new challenges for people who work from home, such as inadequate home setting, social isolation, mental health risks, and lack of sufficient occupational health protection. The second challenge concerns the joint influences of gender, age, race, ethnicity, and social class on working condition and health. It's well known that there are systematic differences in terms of social demographic characteristics of people doing different types of work. So instead of studying the impact of workplace hazard and individual susceptibilities separately, we suggest taking a holistic view and considering their joint influences on work and health. The third challenge concerns the growth of international migrant workers. Each type of migrant workers has its own characteristic and risk profile, those requiring different research approaches and interventions. The fourth challenge concerns the rise of precarious employment worldwide that has been exacerbated by new technology, including the platform economy. Issues of concerns are employment insecurity, income inadequacy, and the absence of workers' rights and social security protection. The fifth challenge concerns working time arrangement. While the average working hours in high-income countries have declined over time, there are problems of irregular or fragmented working hours and the blurred boundary between work and private life. On the other hand, long working hours are still prevalent in some sectors and in some low and middle-income countries, but their causes and health impacts have been understudied. Last, as climate change has been a new threat, research is needed to examine the social pathways through which extreme weather events impact the ecology, economy, environment, and workers' health. More importantly, interventions are needed to mitigate the impact of climate change, particularly for vulnerable groups. Next, please. So at the end, we propose 4 recommendations. First, we suggest health professionals and practitioners to incorporate work as a social determinant of health and adopt multidisciplinary approaches in research, training, and practice. Secondly, we suggest researchers to advance workplace interventions and partner with key stakeholders, including workers' unions, employers, regulators, when designing and evaluating interventions. Third, we recommend reviving the concept of healthy work, viewing healthy and meaningful work as a health-promoting element, and design intervention with innovative methods and analysis. Last, we suggest that before the widespread adoption of new technology, research is needed to evaluate their negative consequences on work quality and health. Finally, I'd like to reiterate that viewing work as a social determinant of health requires active interdisciplinary collaborative research and interventions. We hope this narrative review provides some ideas to advance our research and improve working conditions. Thank you for your listening.
Yes. Thank you very much, Yaven, for the presentation. We go straight to the second and third paper before we enter the discussion phase. So now we come to paper second, and this is about workplace mental health. And I'm doing this presentation together with my colleague Birgit Greiner from the School of Public Health at the University College of Cork in Ireland. So this is a paper 2, work-related causes of mental health conditions and interventions for their improvement in workplaces. And the authors were Birgit Aust from the National Research Center for the Working Environment in Copenhagen, Birgit Greiner, University College of Cork, Ella Ahrensmann, also University College of Cork, Norito Kawakami from the University of Tokyo, Tony Lamontagne, Deakin University, Australia, and Ida Messen from the National Research Center for the Working Environment in Copenhagen. The main message of paper 2 is the workplace offers considerable potential to influence mental health by preventing harm and promoting positive aspects of work, and by facilitating timely, safe, and non-discriminatory support for those showing signs of mental health problems. We come to this conclusion in this paper by structuring the paper with the following topics. We discussed dimensions of mental health. We present results from an umbrella review on the causal role of working conditions in the development of mental disorders. We have a narrative review on the scope and effectiveness of workplace mental health interventions, and we present recommendations. With regard to dimensions of mental health, we distinguish between, first, mental disorders, which are clinical phenomena such as depressive disorders or schizophrenia that are assigned a code in diagnostic manuals such as the ICD-11. We distinguish this from mental health problems, which have a broader range of mental conditions. They also include subclinical disorders and conditions not recognized in diagnostic manuals. And from this, we also distinguish mental well-being, which is not about disorder or problems, but which is about the positive aspects of mental health. This is about thriving, actualization, positive feelings, positive social and psychological functioning. We then do, in our paper, an umbrella review on working conditions and risk of mental disorders. And we picked mental disorders because we thought this is the most challenging. We wanted to examine how good is the evidence that working conditions, that negative adverse working conditions can be so powerful that they actually increase the risk of mental disorders. So we did a literature review of systematic reviews. So this is a systematic review of systematic reviews on the association of working conditions with risk of mental disorders. We only included prospective cohort studies, identified 1,242 records, and we came up with 7 systematic reviews that were eligible. And these had pretty good quality. Actually, 5 of these reviews we rated as have strong quality, 2 moderate. There was no with weak quality. These are our main results. This is a forest plot. It's difficult to read. It's very small there. A forest plot shows the associations. And what we see here on this forest plot that we identified, we extracted from these reviews 26 estimates. And 20 of these estimates indicated that adverse working conditions were associated with increased risk of mental disorders. These are these estimates that are on the right of this line. And we found that we have good studies primarily with regard to depressive disorders. So we can say something about depressive disorders. We can say very little about other mental disorders. But with regard to depressive disorders, we found a strong estimate for workplace bullying as a risk factor for the onset of depressive disorders, and we found moderate estimates for job stress indicators such as job strain and effort-to-reward imbalance, low justice at work, low rewards, and high job insecurity. The conclusion from our review is we identified several adverse working conditions that were associated with an increased risk of depressive disorders, such as workplace bullying, such as the mismatch between high demands, low control, which is called job strain in the literature, such as effort toward imbalance. The reviews included in generally high-quality epidemiological studies. However, also with these high-quality studies, some uncertainties remain to methodological challenges. So there is still also a need for further epidemiological studies that address particularly these challenges. But it's our conclusion that taking all the evidence into account, that the evidence is strong enough for calling for actions, for calling for interventions on working conditions in order to protect workers' mental health. And now we're coming to these interventions, and for the intervention part, I give the word to Birgit Greiner.
Thank you, Rainer. So we reviewed the scope and effectiveness of published workplace mental health interventions to see what is there. And are the slides showing? Can see the slides. Can the slides be? Yeah. So we followed the three components laid out by the best practice model, the integrated approach of workplace mental health interventions. The first component is to prevent harm. That means to protect mental health by reducing work-related risk factors for mental health problems. And examples are here to prevent bullying through good work organization and conflict management structures implemented, also to reduce excessive work demands. Now, the second component is to promote the positive, promote mental health by developing the positive aspects of work, as well as workers' strengths and capacities. Examples are here: supervisor training, team building, increase worker control, such as input into scheduling and influence in decision-making. And the third component is manage illness, so address mental health problems among the working population for those people who already have a mental health issues. And examples are here: possibilities for safe help-seeking, CBT-based counseling, mental health first aid, return to work programs, and workplace adjustments. So components 1 and 2 are preventatively oriented. They are upstream, and they lead to interventions that modify working conditions, whereas component 3 is more downstream and targets people who are already affected. Now, in summary, our review showed that there is some evidence for all the three elements for the effectiveness. However, managing illness is the most prevalent approach in organizations and in research, and by far the most researched intervention approach, with studies mainly conducted in high-income countries and in healthcare populations. Now, our key messages are here now. We need to overcome the focus on solely individual-based downstream approaches in research and practice by developing more proactive interventions with a focus on working conditions, as it was implemented earlier in this presentation. We need also more integrated approaches that combine both the workplace and the individual, and also collaborative and interdisciplinary approaches involving all stakeholders to be instrumental for co-design, context-specific development, and appropriate implementation. These are our 6 recommendations arising from paper 2. First, at governmental level, create policy and systems to regulate and monitor psychosocial working conditions. And we have examples here. Denmark, Sweden, and Japan have legally binding regulatory frameworks, whereas the UK management standards are less binding and more as a guidance document. Secondly, develop and improve policy on mentally healthy work with particular focus on unskilled and low-wage workers to address mental health inequalities. Third, develop practice guidance, how to create and maintain mentally healthy work. We have several well-developed mental health strategies. However, they will fail if they are not implemented right. So for this, practice guidance is needed, and we need here to integrate that into curricula and professional capacity buildings of occupational health professionals, safety professionals, to really ensure good implementation. Fourth, improve governmental support and workplace conditions to enable individuals with mental health problems and disorders to be part of the workplace. Fifth, clinicians play a very important role here, and Australia has, for example, as the only country, clinical guidelines for GPs, how to assess, diagnose, and manage work-related mental health problems. And six, include into governmental mental health strategies and point out the importance of workplace mental health. We have a lot of barriers to overcome here, including stigma and organizational barriers. And here, societal awareness, as well as workplace awareness of the importance of mental health, but also advocacy is important to be successful in this area. Thank you very much, and I hand over to my colleagues, Alex Burdorf.
So, okay, I'm going to wrap up with a short introduction of the third paper. And the third paper is on inclusive labor force participation. And the basic idea is that everyone has the right on paid employment, whether you have health problems or not. This is the paper. I point out the research team, and especially Rita Fernandes from Brazil. She was very essential in bringing the more Latin America into the framework, because I think there is a huge difference between low and middle income countries and high income countries if you look at working conditions and social protection. In the paper, we outline three main challenges, and they have also been already included in the previous two papers. So the first one is, of course, the flexibility of the labor market and the dynamics that goes with that, and the huge role of informal employment. The second one, I think everyone is probably familiar with it, that because increasing life expectancy, populations age rather rapidly, so there is a huge pressure on working until older ages. And the third one, that's really the main message that I would like to hammer down, is that we really should ensure that we create an inclusive labor market. So a labor market where there is place for everyone. I summarize the challenges a little bit with some facts. The first, I think, striking observation is that in many low and middle income countries, informal employment is the default. So it's not highly prevalent, it's the most prevalent type of employment. That's informal employment. And according to the United Nations Women Initiative, well, you can read the figures that women are much worse off than men in many countries. They are the ones in informal employment. And informal employment in lower middle income countries and the precarious employment in higher income countries relate usually to lower salaries, poorer working conditions, no basic social protection, and these are strong determinants of poorer population health. The second one, my favorite figure now for a couple of years, because this figure is an intriguing summary of all the information. So here we have 26 European countries where we do surveys on health, living and working conditions. And if you look at the x-axis, the bottom line, you see the classical health inequalities with lower education, a higher proportion of the group with that particular level of education has a chronic disease. That's the well-known health inequalities. However, if you look at the y-axis and you relate it to the position at the labor market, the health inequalities become even more striking because we see that from higher to lower educated, the labor force participation decreases when you are relatively healthy, but the decrease is much sharper if you have a chronic disease. So the gap between those without the disease and those with a chronic disease, that gap among the higher educated is approximately 10%, and that gap increases to 30% if you have a lower educated level. And you have to read the paper for the factual information about the barriers and facilitators. But the overall, I think, very striking information is that there is a lot of information at micro level, at the level of individuals. And there is less information about the workplace. And there is even almost no information how legislation and policies work to ensure that we have an inclusive labor market. So if you just summarize the literature, you are extremely biased towards individualized problems. And I think with the evidence in the paper, we make a plea that that is, I think, a biased opinion if you only focus at individuals and you make the individuals responsible for their position in the labor market. We need to move away to higher levels. I think that is very essential. So how can we create a more inclusive labor market? Well, I think first we must understand the enormous amount of working years that are lost in the workforce because persons with a particular chronic disease are not able to continue their work. And that loss has become apparent in the, I would say, the last 10 years, because we have introduced new measures to capture the impact of disease on working careers. And I've just highlighted a few numbers here, but there are some specific groups. For example, in Norway, a very interesting paper, that persons who were granted a disability pension, whereby their disease status didn't allow them to work. If you had a mental or behavioral disorder which was diagnosed at a rather early age, on average, that particular population in the Norwegian system received a disability pension for 20 years. So once in the system, you never got back to work. And that's why it was called a pension. And I think that is not where we need to go as a society. And we have ample evidence from literature that sound working conditions may help to mitigate these problems. They can enable persons with disease problems to maintain their workability in the workforce. I think another disadvantaged group where we need much more attention is the workers with impairing limitations, often at early age again, handicaps, limitations. They usually have already a poorer transition from education to work, so their start is poorer, they maintain paid employment with much more difficulty, so they drop out earlier, so they have a much looser contact with the labor market. And why is that important? Because I think the past 10 years, increasingly, we have evidence that on average, work is very essential for your health. I know there are jobs where work is definitely not good for your health, but at population level, being in paid employment is actually beneficial for your mental and physical health. So again, paid employment is a very strong determinant of inequalities in population health. And coming back to my point about legislation, if you look at all the different countries where they have implemented legislation that would support persons with an impairing limitation to have access to the labor market, I haven't done a really systematic review, but I've reviewed, let's say, the most important papers where I thought that they really did a nice job in evaluating the effect of legislation. And the summary is that in some countries there is no effect, but in other countries the introduction of legislation actually increased disparities. And my own country, the Netherlands, is a prime example. We had an introduction of a law and the position of persons with an impairing limitation worsened after the law. How interesting is that? That you design a law to protect people and it has exactly the opposite effect. So we really need to understand that much better. The last disadvantaged group is, of course, workers, older workers. I try to avoid the debate what's old here, but I hope you get the idea that if you have to work until older age, then you may encounter more chronic diseases. And a study of my own research group showed that by introducing legislation again, we indeed saw that many workers worked longer, more years, but for workers with a chronic disease, that extension of their work career came at a price. Because the amount of months that they increased their working careers in paid employment was mirrored by the same amount of months that they spent in unemployment and disability. And especially among the intermediate and lower educated workers, that was a problem because the higher educated workers had financial means to quit their work because they could afford to go on early retirement. So here we see again the link between the health inequalities and work played out. However, there is also very interesting information that if you think about retirement, retirement has different effects on different subgroups in the population. And I guess that in this audience, many people have a pretty good education. For well-educated people, losing their job is almost a catastrophe. And we can actually see that retirement, the first 2-3 years after retirement among higher educated people in many countries is worsening their health a little bit. Whereas for lower educated people, retirement, they bounce back from ill health to better health at a level of the population. So retirement differs with effect on health, but I think that's an interesting observation. So the recommendations that we have in the paper is, of course, that I think we should do much more research on the effect of legislation on disadvantaged groups in the labor market. I think it's an emerging area, but we need to underpin legislation with evidence-based information. I think, but that mirrors also the first two papers, paid employment is a crucial social context. And when I train my medical students, I always explain to them, if you don't know the social context, it is pretty difficult of treating a patient. So understanding the social context, I think, is essential in training physicians, whether they end up in general practice or in more hospital care. I think it's essential. The third one is maybe an open door in some countries, but I think that we should hold employers much more responsible for good working conditions. And in my wildest dreams, I see this pattern that you walk into a shop and you buy clothing, for example. Nowadays you can already read on the label the carbon footprint, but I would like to read on the label the footprint of working conditions and health, so that you understand what is happening with working conditions in low and middle income countries. And I also hope that labor unions use good working conditions as a battlefield, and that they are concerned about informal employment much more than they are right now. And with that, I think I can round up the introduction of the 3 papers and open the
Thank you so
discussion.
much.
Jasmine.
Thank you. Thank you for those really excellent presentations. I wonder if we have our colleague, Dr. Cagliamano, on the call or not. One of our colleagues from South Africa was meant to be joining, but perhaps she can't be here. No? Well, then let me introduce Frank Pager, Dr. Frank Pager, who's a technical officer in the Department of Environment, Climate Change and Health at the World Health Organization. Hi, Frank. Thanks for joining us today. You wrote a nice link comment to go alongside the series. And I wanted to come to you first with a question, and hopefully we'll be able to open it up for some questions from the audience if there's time. But for me, I mean, it's really important, as we've heard today, to understand how the conditions of work impact, people's health. And I know WHO and its partners, including ILO, have developed many different sort of data platforms to try and start collecting some of that data, and presumably for various different analysis. And I just wondered whether you could introduce us to some of those sort of platforms, the way that you're collecting that data, and what you hope to be able to see from it.
Thank you so much, Jessamine, and thank you for this opportunity to talk a little bit about WHO's work and our partners' work on workers' health data and monitoring. So this is a major area of investment for the World Health Organization to build global capacity on data monitoring, because all these changes that my colleagues have just described that are happening around the world, we have to capture them, otherwise policymakers will not know where to focus their attention on. So at the World Health Organization for the last decade, we've invested majorly in building new primarily estimates of risk factors, so how many people are exposed to what kind of risk factor, and then how many people die as a result, right? If we don't know this, we cannot really move forward. And this work was innovative in the way because it brought WHO and the International Labour Organization together, which previously hadn't happened, for creating joint estimates for the first time in history, joint UN interagency estimates. And what we did is we decided in 2016 at a meeting at the International Labour Organization that we would indeed move forward with this proposal of joining hands. The ILO and WHO have a very different makeup. The ILO is the only tripartite organization in the United Nations. And we spent 5 years after this agreement to create our first estimates. And these were actually estimates of how many people die as a result of working long hours. So we've heard long hours several times here, and we were puzzled when we sort of put the numbers together and crunched the numbers that indeed 750,000 people were found, according to our estimates, to die from overwork. And when we released these numbers, these were our first joint estimates to be published, there was sort of a global outpour of support because it came at the time of the pandemic. And as Jessamine, you mentioned at the beginning, this was sort of at people's minds, people working really long hours. And indeed, we found in 2021 the biggest occupational risk factor that has ever been quantified in terms of its health impact. So all these traditional risk factors, dust and fibers, occupational noise, ergonomic risk factors, were shown to be sort of much smaller in scale in terms of their health impact than long working hours. So this was a fascinating thing also to find, because the first International Labour Convention of the International Labour Organization, which was drawn up in 1919, so over 100 years ago, focused indeed on long working hours and reducing them. So it took 100 years for the labour and health sector to actually get together and find out this was indeed what they originally thought, one of the most hazardous risk factors. Since then, we've also published a first joint global monitoring report. So for the first time, these two UN agencies coming together and estimating how many people we think die globally from work-related factors, and it's about 2 million is the figure we put to it. And the striking statistics we found out there was that it's 40% due to long working hours, right? So something we're only just starting to understand in occupational health. And the second key takeaway was that now 81% of all deaths that occur from work are actually due to diseases. But we've almost entirely focused on injuries. Jessamine, I appreciate you in your introduction, you said we've been focusing on injuries and preventing occupational injuries, but not so much diseases. So there was a lot of rethinking, and it sort of revolutionized how we at the World Health Organization thought about work as a lever of population health and what we really have to address. So it's really psychosocial risk factors, long work hours, work stress, that we need to get much closer to, and I think these papers in the series have really highlighted that. And lastly, we didn't just end there, but we actually created some indicators that countries could use, and also us sitting in international organizations, to start systematically monitoring overwork. So how many people in each country are actually exposed to working over 55 hours or more per week. And also we created the first indicator of occupational diseases. So it's extremely curious that in the Sustainable Development Goal indicator framework, we have one indicator on occupational health, and that's actually reported cases of occupational injuries, not surprisingly, right? It's very established. But we don't have anything on the diseases. So 19% of the burden are captured by an indicator and 81% are not. So our proposal has been to basically start monitoring this also as part of the global goals. And yeah, so this has been sort of our work together. And in the comment, to just wrap it up, we actually love the opportunity given by the series to bring together a global occupational health community in terms of an authorship involving the Minister of Health of Somalia. We had the two heads of national institutes of occupational health in the US and in China come together. Dr. Kalangomo, who should be online, but I apologize on her behalf. She's in an area in South Africa where internet is actually intermittent because of power outages. So today, unfortunately, she must have encountered a power outage. And we basically started thinking together of the sort of things that are missing really in monitoring systems. And that really involves now having to focus much more on workers' rights, right? So I loved the presentation you gave, Alex, on inclusive labor market practices that are needed. And so we argue we need indicators on rights, right? If we don't know if workers' rights are being violated, we can't help address them and remove them, right? Similarly, we now need to start not only focusing on reported cases of occupational injuries, which are easy to count, and even they are often missed, but we need to focus more on working conditions in general and diseases so that we can capture things with the biggest burden and prevent it. And then finally, we argued something that admittedly global occupational health hasn't been great in, I think probably most panelists would agree, has been monitoring inequalities. So we really need to know which workers are sort of most disadvantaged, and we need to focus on them. And finally, to say that, yes, there's been a great focus on occupational health in many high-income countries, but the focus needs to shift from a global perspective to focus on lower middle-income countries. In our comment, we had authors from the heads of the Ministry of Health in Togo, in Nepal. So a number of people are now joining the call to basically focus on monitoring also in lower middle-income countries.
Thanks, Frank, and it's such a shame that they can't join us today. I just wondered whether we could build on that, because, it's interesting that often governments, they focus on whether people are employed or not. That's their headline figures, that's what they're interested in, that sort of feeds into their own political narrative. So how have you, and this is for, a question for all of you really, how have you found government's response to thinking more sort of about more, a kind of more capacious view of working conditions and health? Is there interest there, and what needs to happen to sort of move that agenda forward? Maybe Rainer, you could start.
Yeah, Gavin. Well, if if I refer to the country where I'm coming from Denmark, we had a couple of years ago the first executive order on the psychosocial work environment. I think this was a major step. The Swedes did this a couple of years earlier, and then Denmark also joined on this to put together and sharpen the legislation on working environment. So there is some interest, but of course this is always a struggle, and this goes back and forth, and with economic cycles and different interest groups. I think in the Nordic countries it's relatively high on the agenda, the work environment, but I completely agree what you are saying, Frank, that it's important to make this a global movement, and was very happy and also to see this in your commentary, because in our papers, when we wanted to have the high level evidence, and this is very much focused on the high income countries, and important to go global here. Yeah.
And might we hear online from Yaveng?
Hi.
Hi.
I think that I think in Taiwan and many East Asian countries, long working hours are still the major problem, and irregular working hours and overwork problems are the major issues. But recently, workplace violence and harassment and workplace bullying has been targeted. So in Taiwan, we do have the legislation focusing on these issues. But other than that, I think there's still room for improvement concerning other aspects of work quality, like low control or low effort or low social esteem. Those are important issues that workers are concerned about. But I think regulation or the societal values still need to be improved. Yeah.
Thanks for that summary. That's great.
Yeah.
Does anybody else on the panel want to talk about this question in particular?
Yeah.
That would be lovely. Thanks, Alex.
Yes, so I think in many countries we have now introduced these new measures that capture the working career that people have, like how many, on average, how many years are people in paid employment. And that's quite interesting, because usually policymakers, but also researchers, they think, someone starts at the age of 20 and they have to work till 67, so that's 47 years. But that's only a tiny proportion in the whole workforce who actually manage to work continuously during working career. So at population level, many years are lost. So in the Netherlands, we did an analysis, and higher educated, they will lose on average 7 years, and lower educated on average 15 years. And that's because they are unemployed, they are in permanent disability benefits, they simply run out of having paid employment because they are in a partnership and the work kills them, so they simply drop out of work, which happens a lot with women. And if you add up these numbers, then it's much more convincing to policymakers, to economists, to show, well, if you want to create wealth in a society, you need to create health in a society. A healthy workforce creates wealth. So my strategy now is to publish in economic journals on these issues. And that's very interesting, because they have a completely different way of looking at science, but I'm trying to cope it. But it works, because now we can link debate about pensions, wealth, to the health. And I think that is something that we should do more often.
Thanks, Alex. Yes.
Yes, I mentioned in my talk that most of the research about workplace health interventions was done with healthcare workers, and apparently we need research in other industries as well. But the healthcare population is actually an interesting one, and has come to center stage now also in high level reports about retention, we have a retention problem in healthcare workers, and many are leaving the job because of burnout and poor working conditions, which causes a crisis in this area. And so the whole aspect of retention is an important one for those very substantial industries and areas of work. And in the US, it has been now discussed also in kind of performance enhancement initiatives in hospitals to introduce a fourth aim, apart from enhancing patient satisfaction and more effectiveness in the healthcare delivery. It is the health and the mental health of the healthcare worker. So work needs to be organized in that way to be able to really practice retention in this area.
Thanks so much. Yeah, Frank, and we've got 5 minutes left, so if you can make your, just in case there's any burning questions from the audience, because this is a short session, because they need to get ready for the opening ceremony.
Then I'll be super quick. I just wanted to say that we generally find governments to be very interested in workers' health, but not only as an economic population, right? Workers are people, they're also communities, they're populations, and the health sector has a unique approach, other than maybe other sectors that might look at a more economic lens, or a labor sector lens, in making sure that we have healthy people, right? So I think the health sector plays a key role here, and maybe sometimes it needs to push for looking at the root causes and pushing for prevention, as opposed to conceptualizing people as economic players only, or as an economic resource.
I couldn't agree more. Yeah, that's lovely. Thanks, Frank. Does anybody have any questions before we wrap up? Yes, at the back there. There's an arm that shot up. Yes, yeah. I don't know if there's a mic, or I think there should be. Perhaps there's not. Maybe you can just ask it. We're quite a small group.
I can shout. So I'm Anthony Renshaw. I work at International SOS. We provide occupational health support and advice to some of the world's largest organisations. My question is this: we're seeing similarly a desire among employers to do more for population health. What avenues are there for organisations like ours to help galvanise this change? I'm aware of some global forums that have been set up recently, but can you tell us a little bit more about how you're actually going to get employers to make the changes that you eloquently recommend?
Thanks so much. Great question. Who'd like to take that first? Alex.
Yeah, so I think in some areas like the healthcare, which is obvious that if you as an employer don't provide optimal working conditions so that your workers can remain in the workforce longer, it will backfire tremendously, because we need all these people in the healthcare sector. So that's a given. Education is the same. So I think there are strong driving forces now for employers to make it possible to work longer in good health. That would be my summary. Whereas 10, 15 years ago, at least in many Western countries, you had systems where you could get rid of people with health problems and you simply hired a new batch of workers. And that's no longer possible, because the workforce is aging rapidly, and so you need to accommodate. You need to make the workplace a much better place than 10, 15, 20 years ago. That would be my best bet, how to create change.
Thanks, Alex. Frank, are you gearing up to say something? I think we've got seconds left, or less than a minute left.
For me? Okay.
It looked like you were going to say something.
I think it's a really interesting question. I think that governments have a lot of power to regulate. So regulation is one way of how we can actually make sure that working conditions are safe and healthy. And I think that's a key avenue. It's not only making sure that employers are happy with conditions, but governments can also regulate. So that's another key avenue.
Yeah, Wang online, I wanted to give you the opportunity to answer this just in case you had anything to say before we close out.
No, I'm fine.
That's it. Well, I think, we're now at time. All right, well, thank you so much. Thank you to the presenters and the speakers. Thank you for joining us online. Thank you for joining us here. And yes, thank you very much.
Thank you.